Regards to all friends of Dental XP. I want to thank you all for your comments in my previous presentations. I have presented in other presentations different techniques and material options to improve the shape and proportion of the teeth. In aesthetic dentistry, we have, in general terms, two material options with different molecular structures, which are ceramic materials and polymeric materials, also known as porcelain and composite, or even more informally, glass or plastic. We cannot say that one is better than the other because both have different characteristics given by their different molecular structures. This time, I would like to talk about ceramic materials. Ceramics have several physical properties, but the most important properties in which we should base our decisions are translucency and strength. Translucency is directly related to aesthetics, while strength is directly related to durability. When we base our choice on translucency, we look for better aesthetics. We can see that feldspathy has better aesthetic properties because when the light influences its layers, feldspathy has a selective capacity to let the light go through, absorb, and reflect in the same way than the natural tissue does, allowing some rays from the spectrum range to pass through while reflecting others. So, feldspathy has an excellent selective translucency. The lucite and lithium disilicate have lower level of translucency. The alumina and zirconia have even less translucency. However, nowadays the manufacturers offer us translucent zirconia, but it is not translucent enough. On the other hand, when we base our choice on strength, we can see that feldspathy has lower strength than the rest, followed by lucite, which is stronger, lithium disilicate, which is even stronger, and alumina and zirconia, which are the strongest materials. So, the advantage of the materials on the left, feldspathy and lucite, is the excellent translucency, which means greater aesthetics, and its disadvantages are lower strength and no ability to mask. The advantages of the materials on the right, alumina and zirconia, are the higher opacity, which allows us to mask dark cores, greater strength, which allows us to make multiple units and parts of implants, and its disadvantage is poor translucency. So, when making our choice, we should ask ourselves, what do we want? Greater aesthetics or greater strength? Or maybe a material that has a little bit of both properties like lithium disilicate, more commonly known as IMAX, or even better, the lithium silicate. So, in order to adequately choose, maybe it would be important to ask ourselves, when and where do we need these properties? If they are front teeth, we need greater aesthetics. If they are back teeth, we need greater strength. If there is bruxism, we need greater strength on the front teeth as well as the back teeth. If there are dark cores, we should mask them. Or if we want to be minimally invasive and we don't have enough workspace for the restoration. State-of-the-art technology offers conservative and aesthetic alternatives to re-establish the shape and color of the anterior teeth. So tooth reduction for any restorative technique obliges us to be as conservative as possible, even though some rules have to be followed. And this is one of those alternatives developed by this brand. It came on the market not very long ago, about 3 years ago. These are lithium silicate blocks. Not this silicate. This is silicate, which has better properties than lithium disilicate, or IMAX, like better color properties and strength, according to some studies. With these blocks, we can process veneers in CAD/CAM up to 0.3 millimeters thick. But demand and desire for even more conservative preparations begins to drive the new area of no-prep veneers. Even though, contrary to common thinking, this style of dentistry is not easy. In fact, if done well, this approach can require more skill and expertise than traditional porcelain veneers. Here we have some indications for no-prep veneers, and all of them are related to the need of increasing the size or the volume of the teeth, like macrodontia, such as pec laterals, short-worn teeth, as well as others. As we can see, according to some studies, no preparation veneers are indicated for selected cases only, and a larger number of cases require some kind of tooth modification for superior aesthetics, patient satisfaction, and better color change without affecting the thickness and emergence profile of the veneer. So, to prep or not to prep? That is the question. And the answer is given by an accurate diagnosis. According to ceramic materials processing techniques, there are three main or more common techniques, which are stacking, which is the most common and oldest technique. Most of us are familiar with it because all of us have placed crowns on bridges made with it. Pressing was developed later. It is also popular because it has allowed us to make more aesthetic work with only ceramic due to its greater strength. And milling, or CAD/CAM, the latest technique, which revolutionized the world of dentistry. But notice that this technique isn't really new, because in 1985, the first feldspathic blocks were already being milled. Later, in 1993, lucite blocks began to be used. In 2005, lithium disilicate and zirconia blocks for the structures were used for the first time. In 2007, polymer or composite blocks were used for the first time. By 2012, nanoceramic composite and translucent zirconia blocks appeared. About 3 years ago, in 2013, after a long time of developing, the first hybrid ceramic and lithium silicate came on the market. CAD/CAM techniques may include structures, cut back and layering, and monolithic. Let's talk a little bit about monolithic technique. What are the advantages of working with CAD/CAM or monolithic techniques? First, greater strength. The CAD/CAM offers 400 megapascals, while stacking materials only offer us 100 megapascals. This is because the blocks are industrially pressed by the manufacturers, which makes them more resistant and compact. Greater marginal adaptation. With CAD/CAM, we only have 25 microns or marginal discrepancy, while other techniques have 80 microns of marginal discrepancy on average. For example, the metal ceramic crowns, which are a traditional type of crowns often used in bridges and also in crowns. The several steps and the complexity of the procedure of metal crowns can create risk of occurring adaptation issues. Work time. With the CAD-CAM, we can process a restoration in only 20 minutes, while stacking techniques takes 5 hours on average. The CAD-CAM also has great versatility in treatment options and materials for excellent aesthetics and function. Finally, the CAD-CAM offers us predictable, consistent, and highly accurate results. What are the disadvantages of working with CAD-CAM? The cost of the systems and materials, and perfect preparations. When I say perfect preparations, I refer to the fact that the CAD-CAM system demands us to prepare the teeth perfectly before taking the impressions, because the system captures every little mistake, like irregular margins. But I don't consider this a true disadvantage, because that encourages us to improve our preparations by using magnification, appropriate burrs, etc. Now, I'd like to show you a case managed with ceramic using monolithic lithium silicate ceramic veneers and the cutback and layering technique. This is Joanna, 26 years old. We begin the process as usual with a facial analysis, in which we have determined that her facial thirds are well proportioned. She has a type 1 profile, showing her lips behind the E reference line. While smiling, we can see a large band of gingival tissue and a moderate inclination of her occlusal and gingival planes, which does not maintain an adequate parallelism with the interpupillary line. She has medium lips and a dental exposure of about 4 mm at rest, which is the average for young women. While smiling, we can see a high upper lip line and a gingival exposure of more than 4 mm on average, which is considered gammy according to current parameters. She has a class 1 occlusion with good intercuspidation, square incisors, and her anterior teeth are slightly protruded. So we planned aesthetic crown lengthening for Joanna in order to reduce her excessive gingival display and improve the inclination of her gingival plane. We also planned the placement of 10 lithium silicate ceramic veneers from 4 to 13 to improve the shape, size, and position of her anterior teeth, as well as the inclination of her incisal plane. Prior to the wax-up, we outlined the limit of the desired arch shape to perform the most conservative reduction of the needed wall thickness for the veneer, making the same reduction that we are going to do on the natural teeth, being as conservative as possible. Then we perform the anatomic wax-up, which has two objectives in this case. First, to have a preview of the final result. Second, to make a silicone index, which can be used to make a mock-up in order to perform the most conservative preparation of the teeth. The surgical and clinical procedures begin with the aesthetic crown lengthening. This is a retracted view 1 week after the procedure, and 2 weeks later, the periodontal tissues are undergoing the healing process, showing an excellent response. We began the preparations by making the most prominent part of the anterior teeth, which have a moderate inclination forward. Now we proceed to reduce the marked part of the facial wall of the teeth in order to stop the protrusive teeth from passing through the mocap. Then we placed the temporary resin material in the silicone index on the teeth, and the mocap is ready. Now we proceed to reduce the facial surface of the teeth in order to obtain the needed wall thickness for the veneer. But take notice, we are working almost entirely on the mocap material in order to perform the most conservative enamel preparations. Taking out the excess material, now we proceed to prepare margins, creating a rounded shoulder. Sharp line angles should be rounded. Prior to the impressions, we place a 3-0 retraction cord. A second retraction cord, number 1, is placed. The silicone is placed on the margins while we are taking out the second cord. More light silicone on the facial surface of the teeth and lightly air-thinned. Then we place the tray with the soft putty inside. Now we are scanning the wax up in order to obtain a biogeneric copy, fitting the virtual veneers on the digital model, fitting the veneers in the block. These are lithium silicate blocks which are being milled by the machine to replicate what was scanned by the system, because we decided to make monolithic CAD/CAM ceramic veneers. Now we are manually cutting back the incisal thirds of the 4 incisors. This allows us to stack some porcelain layers in a sequence with the goal of recreating the natural layers of the incisal third of the anterior teeth, which is the most critical part in terms of aesthetics. Then the layers are fired and then finally glazed. After drawing a characterization diagram, mechanical shaping, texturing, and polishing is performed, following a specific protocol to fully develop the desired natural texture and shine of the buccal surface of the teeth. Canines and premolars were only stained because they are monolithic. After the final glaze, the veneers are ready to be tried and loaded. Acid etching, rinse and air dried, adhesive was applied to the facial surface and lightly earthened. The resin cement was applied and the veneers were placed. each tooth light cured for 2 seconds, removal of excess partially cured resin cement prior to the final curing. The interproximal excesses are also removed, and then the restorative interface was finished and polished. Thank you very much.